to try to help. And part of it, again, is thinking in the context of where we are. So is it school versus at home versus both? And that's one of the things to keep in mind, as a lot of you are already, I have to remember that I'm speaking to a lot of you guys I know a lot about this already. But one of the big questions always is, do we see this globally, or do we just see it at school or at home? Right? Very often I'll have parents who will say, like, I don't understand. I hear from the teachers, like, my child is an angel. I have one of these right now, but at home, she just is like a wrecking ball. And we're like, nah, well, then that's probably a behavioral thing, right? So some of these things, but we're primarily looking for how we deal with this within the school setting and how it affects the school. Okay. So today we're looking at how we defining anxiety, what kind of effects can it have, and what can be done. And the goals, again, is to try to figure out how we kind of view and think about these things as we move forward. Okay. All right. So with that in mind, most commonly what I get is when someone calls me is I get this, I have anxiety, or my child has anxiety. And I will ask them, my first question is, well, how are you defining anxiety? And that's one of the big questions. Is it has a general term. I can be anxious, and some people will use anxious and stressed as the same thing, versus I have a diagnosable disorder. Right. And even when people say I have anxiety, so I'll have people say, I have anxiety. It's kind of like a classic, like I'm constantly worried, or, there's an issue that I can't seem to let it go of. That could well be anxiety. The flip side is all people say, my child has anxiety. I'm asked, what do you mean by that? And they'll say something like, well, he screams at me and throws things at me. And I'm like, well, that could be anxiety, but I have lots of people who have anxiety who don't yell and scream and throw things. So that may not be anxiety. So one of the first things we really do is trying to define what do we mean by anxiety. In the school setting, especially when kids are anxious or they say they're stressed, the question, one of the big differentials is acute versus chronic. Is this an ongoing, constant, consistent theme of their life, or is it only given certain situations? Right? So I would expect someone to have anxiety or general quote anxiety or general stress if I'm taking an AP, if I'm asking that cute guy or girl out for the first time, or I see them walking towards me, if I'm about to play if I'm starting in a game, right, or right before a drama performance. Those are things that I would expect, right, where I would have acute stress, acute anxiety that is and here's the key point, that is likely to pass when that is over. So if I'm nervous about giving speeches and it's time to give a speech and I'm getting in front of the classroom, I would expect my heart to be racing. I would expect to feel a little bit clammy, a little bit unfocused, and that would be normal, right? As opposed to, and I would also expect that to go away once I get back to my desk, and about 5-10 minutes later, my heart rate's coming back down. Whew, man, I didn't like doing that. I'm glad that's done, right? That's normal, and I would expect that. As opposed to a chronic situation, and here's where that crossover is as well, though, is I can have chronic distress in that situation where, oh my gosh, this is so overwhelming, I can't do it. So it's not just the day before I might have a little problem sleeping, or the day of I get anxious. It's like, again, if we're looking at that chronic social anxiety disorder, what if I say something that embarrasses me? What if I flush? What if I get sweaty? What if there's something tucked in my teeth and I didn't even really notice before I got on or got up in front of everybody? What if I forgot my lines? What will other people think, from the teacher to the other students? And it's to the point that it inhibits my ability. And that's that big difference. When it actually starts to interfere and inhibit with my ability, now we have a problem. So that's when we want to usually step in. So the acute stuff, as long as it's not overwhelming and we can learn to tolerate, that's actually what we want, because we're trying to build distress tolerance. We want them to get used to those situations and they do it over and over and over again to the point that it's no longer distressing for them. And we'll talk about that in the framework of cognitive behavioral therapy. But the goal is, hey, we want them to tolerate distress. We want them to get used to things, not get away from them to the point that I don't have to do it. And then they never do it. And then it always is a weakness and they're never able to do it. So we want to build them to the point they're actually able to do it on a consistent basis, even when they're anxious and uncomfortable, as opposed to having a chronic situation in which I'm just so overwhelmed. And the only other thing to keep in mind with anxiety disorders is, in that moment, any one of the anxiety disorders, they might likely have a panic attack, right? That increased heart rate, that shakiness, the feelings of unsteadiness, and feeling overwhelmed. And one of the key things to keep in mind as we go through this is, what is the underlying cognition that's driving it? what is the underlying cognition that's driving my fear or my anxiety? Is it, for example, with panic disorder, I'm going to have a panic attack and I'm going to pass out, or I'm going to go crazy, or my body's going to freak out. I might lose control of my body. I might urinate, defecate. I might, all of these things, but it's based on how my body feels, as opposed to, oh my gosh, if I'm sweating, everyone's going to see it. And they're going to hear the stutter in my voice. And that's the embarrassing part. I might feel panic. I might have a panic attack, but it's the embarrassment that's the issue, as opposed to how my body feels. Okay. The generalized anxiety disorder, you're currently, oh my gosh, if I mess up this presentation, I'm going to get a zero. If I get a zero in this, I'm going to fail the course. If I fail this course, I'm never going to college, right? Then we have that generalized anxiety, as opposed to a specific phobia of like speaking or test taking or something similar. So one of the big questions is, again, separating out kind of the acute from the chronic and knowing that differential. Okay. Let's see. So in that same way, we also have to remember, most of these things don't happen in a vacuum, right? So we look at the other complicating factors, and some of the other diagnoses that we have also overlap, are seen as overlapping symptomology, excuse me, as well as can be seen at the same time. So depression, right? We can see fatigue, but fatigue could also occur with generalized anxiety disorder. Sleep issues can be mood. It can also be anxiety, right? ADHD, distractibility. I can't focus. Well, can I not focus because I'm not hearing every fifth word because I have ADHD? Or is it because of something else? Like I'm so focused on like my heart racing that I can't focus on the test. I'm waiting for my heart to burst. I can't focus because, oh my gosh, it's pounding so hard. I can't actually sit there and do my test taking, right? So we have to, again, separate these things out. Other things are learned behaviors, successful strategies. Some of them can be successful, right? And they can actually learn, hey, I'm learning to endure this, versus successful of I'm crying and my teacher allows me to leave. And then what do I learn? Oh, if I cry or throw a tantrum or get angry, or if I just don't show up and the teacher says that's okay, or doesn't say it's okay, but I still get pushed forward a grade, then I've learned that, oh, I have successful strategies, right? So we're looking to help the person get through this and learn to tolerate things over time. And again, we'll talk about those things. The other would be cultural environmental factors, anything from my ethnic background that has an effect of the Asian culture, very high pressure and stress on academics. Academics are primary. And if we look anything from historically in the United States, where Asians were not given the same opportunities, even right now, I think it's Asians have to score 400 Asian males have to score 400 points higher on an SAT, right? So if you're already at 1200, or if you're at 1500, you don't have another 400 points. So how does that affect me in terms of, I'm supposed to be a high performer, I'm having problems moving in this, and there's nothing else for me to do, and I'm stressed out because my parents say I have to go to Yale, and I have a 1500, but I don't know if I'm going to get into Yale with a 1500 or 1400 because that's not high enough. So what do I do with that? What are the expectations of my friends? Right? Either performance on the field, to performance in the classroom, to dating, right? So I have all of these different complicating factors that can play into that. One of the things that we look at when we discuss anxiety is the concept of interference and distress. And the idea is, how interfering is this in my life, and how distressing is it to me or my family system? So interference, again, is not just like, hey, I'm still getting like B's, that's pretty good. But if I could performing at an A level, right? Or if I'm getting C's, but I could be a B student or even an A student, it's affecting me. And a lot of these kids, unfortunately, just kind of slide by because we don't notice, because they're doing well enough. But in reality, they could be performing better. So again, we're thinking about it as a, not necessarily as an absolute A or F, but in those in betweens, those relative weaknesses and strengths, and how do we help them maximize their own potential within that? As well as how much distress do I feel just by having this stuff, and how is this affecting me? So those are some of the things that we talk about when we talk about just I have anxiety. So again, so when we talk about I have anxiety, we talk about it, acute versus chronic, and then what complicating factors go into that, and then interference and distress. So this is kind of when people call me, I'm thinking about these things already. So when they say I have anxiety, what do you mean by anxiety? And am I thinking acute versus chronic? Because if it's an acute thing, hey, we could probably send them to a general counselor to get some relaxation techniques or some things to help them through that moment, maybe some grounding techniques to get through that moment, which is going to pass, as opposed to, oh, we have a significant disorder that's significantly interfering and distressing in your life that we need to address. And then that's a different ballgame. Okay. So again, when we look at anxiety, we're thinking about it from general stressors. And again, remember, moderate level stresses actually increases performance, right? If I don't care about the test, look, this has no effect on my grade. I don't care. I'm not studying for it. I have no stress and I'm going to perform lower. If it's this one question is 100% of your grade and it's oral in front of the whole classroom and it's 2 hours long, oh man, that's so much stress that it's going to actually impair my ability to give that information. It's going to decrease my performance. But a moderate level of stress is actually good in terms of performance. But in general, there's stress. It tends to be short term, so it's going to terminate at some point, and something that everyone commonly experiences, as opposed to a clinical issue, which is we have a specific classification in the DSM, the Diagnostic and Statistical Manual. I'm sure you guys are familiar with that, and they have specific symptomologies that cause interference and distress. And the good thing about this is we know there are actually ways to treat these things. And that's where we also want to be able to step in, both within the school to some extent, and then if we're doing clinical work outside of that. Okay. And we're just talking a little bit about this in regards to what are the effects of this. Generally, we can have a potential lower performance, but often it actually increases if it's a moderate level. It can affect your mood, increase your cortisol. But we can also learn to tolerate distress and move into it, or potentially I learned that I always fail at everything. So a lot of it's that mindset versus clinical things where we're looking at the effect on performance, including avoidant behavior. How do I get out of the situations? We often see, not surprisingly, anxiety and mood go hand in hand. The question, and something to think about is also, is the mood separate and unique from the anxiety, or is it a cause of anxiety? Okay, and this is kind of important because sometimes we don't have to treat the anxiety or the depression directly. We can just work on the anxiety and the mood lifts on its own. So, for example, if I have social anxiety and having problems getting to just even hang out with my friends, and I'm not hanging out with my friends, and I get invited out, I say no, I stay at home, I don't get that social reinforcement. I feel embarrassed that I didn't go. I might even feel kind of angry at myself. And the next time they ask, I feel even more embarrassed, and I'm going to keep on stepping away, and I start to lose that social network, which then affects my mood. If I'm able to step into my social anxiety, normalize it, stay in the situation, hang out with my friends, recognize, oh, this is okay, I'm good with this, then that changes things, right? And then my mood might start to lift because I know, hey, my friends are actually here for me. Hey, this is really good. And then my mood might start to increase, and we may not need to directly address it. I would say at least 60, 70% of the time of what we see, we don't directly address the depression. Because like panic disorder, I can't leave the house because what, I have a panic attack. Well, I can't go to work. I can't see my friends. I can't go to school. There's all these things I can't do and that are removed, and I get more and more depressed. Once we're able to get functioning and be back in those situations, then they have all of that reinforcement again, and they really enjoy it, and we don't need to treat it. However, there are absolutely times where we do need to address it too, and that's something to keep in mind. We do a lot of behavioral activation. We can talk a little bit about that later if we want. The other important thing is when someone has a clinical issue, counseling techniques don't work. Deep breathing, relaxation, progressive muscle relaxation, those sort of things, they're not going to work. And the way I'll describe it is if I have a clinical issue, I, at some level, feel like things are going to go horribly awry. So in the same way that I have a fight or flight. So if a bear comes through my door, right, I have an automatic, I don't even have to think about it. My base part of my brain says teeth, claws, giant predator, it's going to kill me. It lights off my fight or flight. In the same way, though, if someone says, like, if I don't pass this class, mom's going to kill me. And this class is based on how well I do on this test. So I'm thinking in my head, oh my gosh, this is catastrophic if I don't pass this. Okay, that's this cognitively mediated panic attack, but I'm still going to have that response. And when I have that response of that panicky, like that panic attack, that fight or flight. So panic attack, same thing as a fight or flight response. So if a bear comes through that door and you tell them, hey, it's fine, just like take some deep breaths and relax. It'll be fine. It's just a bear. The bear's going to kill me. You can load me as much Xanax as you want. I'm still going to have a fight or flight response. It might be muted, but I'm still going to have a response. Why? Because this is catastrophic. There's going to be a horrible, horrible outcome. And because of that, deep breathing, relaxation, these other things don't work. And then they get frustrated. Your students get frustrated and angry because I've been told these things should work and they're not working. And now what do I do? Like, why would I listen to anyone else now? Because everyone's telling me to take a breath. It's fine. Just relax. It's okay. And it's not. And your techniques don't work. So just be aware of that too, is when we look at clinical issues, counseling issues of conversely, hey, I'm going on like to the prom with someone and I really like him or her, taking some breaths or doing something just to kind of, okay, let me just take a minute here. That's okay. Same thing with APs or otherwise, right? Okay, let me just, before I open up this test, okay, I can do this, right? That's very different than Bear coming through the door. Okay, let me pause for just a minute. If you guys have any questions, just to the up to this point, let's just take a second here. If you guys have any questions, feel free to go ahead. Any questions?
I have a question. What you said before about, if it's really clinical, then using techniques like breathing and stuff like that isn't going to work in calming a student down. So let's say that we have putting it into a lot of our own like current roles. If we have a student who's in class and is kind of having or experiencing that fight or flight and is unable to like really work well in class, or maybe they're causing disruptions, or maybe they're really visually upset, what would be your recommended course of action to kind of help this kiddo regulate to ideally, either get them back in class or to kind of help decrease their stress levels in that moment?
That's a great question. And we'll talk a little bit more about some of the things we can do. I would say number one, it depends on what the situation is. So it depends on what I'm afraid of in that moment. Is it a trauma, right? Am I walking to a classroom where there's, it reminds me of a situation where I experienced some trauma versus there's just, this is like, if I don't pass this test, I am really sunk, right? So there's different reasons of why they might be dysregulated. And that's one of the questions. Why is a student dysregulated? And how do we help them in the moment? Unfortunately, there's not a lot we can do. You can try to do some grounding techniques to get them be aware of their surroundings, but in the moment it's almost too late. It's kind of like when you have a kid who's tantruming, right? What do you do when the kid's tantruming? Well, the kid's tantruming, screaming, yelling, crying, like lashing out. You almost kind of write it out. So when we talk about panic attacks, one of the things you remember, panic attacks are only about 30 seconds. 30 seconds, maybe a minute. Why? Because think about like sprinters. 200 meters sprint is roughly 20 seconds, and those guys are gassed, right? When we're talking about 400 meters, you actually have to pace out your race because you can't go 100% the whole way, and that's about 40 seconds. So now they might have waves of them for hours, but their absolute peak is only going to last about 30 seconds. So can I get through 30 seconds, take a breath, and then let's try to talk a little bit and then could re-engage. But the idea, you can try some grounding techniques at that point, get them kind of focused. But in the moment, it's actually almost too late. So we talk about, you'll see, we'll have a slide called pre, mid, post. And a lot of it is actually, what do we do before that actually happens? How do we prep our kiddos before they enter the situations rather than, well, you're in the situation, here we go, right? We want, and then give them enough information, ability to kind of ride through the discomfort of the situation, and then look at it when we're done to see, hey, how did that actually go? How bad was it? So next time it won't be as bad. So we'll get to that, but that's an excellent question. That's a good preview of what's upcoming. Any other questions? Okay, let's move forward then. So,
sorry, we have a question real quick, if you don't mind.
sure.
We were wondering if we do, like, a student is exhibiting like chronic anxiety in the classroom, but a parent's not ready to see it for their student yet.
Oh,
how do you proceed?
That's a great question. So you're essentially saying student sees it, parent or teacher see it, parents don't see it or won't interact. Is that about right?
Yeah, that's what I mean.
Okay, so sometimes, especially if the parents aren't willing to say, hey, there's a problem, like, it's okay, he or she just needs to learn how to handle this, like, or they'll get better, or this is a one-off, or however they're kind of expressing it. Coming from I'm a data guy. I'm super nerdy. I like statistics. I used to teach it. I used to do research methodology. So one of the things let's just look at the data. What does the data tell us? The data tells us your child doesn't do well in test situations. Does fine on the homework, is really diligent, tries hard. We can see that, does great, and falls apart in a test. So we see this consistently, not only in math, but we see in science. So we can see it across the board in different situations where this is happening. And he's just Jill's just not doing well. So, and if the parents are like, well, no, we'll figure it out. We can do this as a family. Like, okay. So then I would say two things. And number one, let's set a time frame for how long you guys try to right the ship and define that. Does that mean going from like F to C's or C's to A's? Like, what does that actually look like as defined as my child is now successful and doesn't need any continued intervention? The other thing I would ask is, what happens if we keep it the way it is? What's if we keep on pushing historically, not only this year, but last year or the years before, what do we see likely going to happen? Because the best predictor of future behavior is past behavior, unless we have a change in the system. So we can expect the same things to happen as we keep on moving forward, unless we make a change. So this, if we leave it the way it is, this is likely what's going to happen, or what we would see happen also from your own experience and what you see with the other students. And this is what we see if we make a change. So it's really up to you guys and up to to Jill, but you guys need to think about, number one, can you make that change? And if you do, what does that look like so we can define it, so we operationalize it, so everybody knows, oh, we are now successful, we're good to go, versus no, we're still struggling. And what happens if we keep it the way it is, or where are we likely to go? And then it's still, because ultimately, the parents play a huge role in this. A lot of it's going to ride on their buy-in. And that's the way I would try to set it up and set a time frame. Like, hey, let's try this for the next 3 weeks. If we see significant improvement, then you guys did a great job. But we need to also define what that significant improvement is, how to quantify that, so we actually can measure it and say, yes, this works, or like, no, we're still having a problem. Okay. Does that answer your question? Oh, you're on mute, so you've been muted. So I don't. Okay. All right. Let's move forward a little bit more, and then we'll ask more questions then. Okay. So what do? So one of the questions is, so if I have a kid who's melting in class, right? You guys get a call. Hey, so and so, Jill's melting in class. You go there. Then you have to figure out what's going on, right? So what's the presenting issue? What's the issue that needs to be addressed? Okay. Then again, if it's can I give this individual short-term strategies for acute issues? Right, I'm really nervous about the cross-country meet this afternoon. Like, I'm a little bit injured. I'm just coming back. Everyone's just expecting me to perform really well. I was hoping to PR this season, and I don't know if I can do this. Right, that might be. Oh, then we're looking for short-term acute strategies. Strategies for acute short-term issues. Like, okay, let's just think it through a little bit, and then let's give you some, like, what does coaches tell you? What are the actual expectations, and so on. So that's one way. Versus, do we have an IEP for the student? What are we supposed to do? Right. So if we have a good IEP, that will set up the stage for how we're going to follow that for that individual. If we don't have an established strategy, then we look for either, what do we know from research, what will work, and how do we eventually set up an IEP, as well as thinking kind of like what I was just mentioning before, that idea of like pre, mid, post. What do we do before, in the middle of, and at the end of these sessions, or excuse me, of these situations? Okay. So when we talk about it from a school-based approach, is we want to, again, prepare the students ahead of time. So there'll be, the next slide is a 3-component system. So think of a triangle: cognitions, how am I thinking, physiological, emotional response, how do I feel emotionally, which is very often fearful, what are my emotions, and physiologically, increased heart rate, shakiness, feelings of unsteadiness, dizzy, upset stomach, heat, cold flashes, tingliness, all of those things. And then what is my behavior? Typically, I'm going to try to run out or avoid that situation if I can. Okay. So can we prepare the students ahead of time? Hey, before the meet, you should expect to have tingliness. You're not going to be able to focus well in class today. Your stomach might feel upset. You might notice your heart racing. All of that's normal. You're gonna have thoughts of like, I can't do this, or I don't know if my ankle's healed up enough, or what if coach is disappointed in me? What if my friends razz me afterwards because I just didn't perform well and they're expecting me to at least place in the top 5? Like, what are my thought patterns, right? And then you can start actually walking them through and cognitively challenging those thoughts and seeing, hey, what's a realistic outcome versus what do I fear? And starting to normalize those things, as well as what are my behaviors? Am I going to be constantly like rubbing my hands? Am I rubbing my face? What am I doing that can also recognize I'm doing all of these things? So when I'm in that situation, none of those are a surprise. Totally expected those thoughts to come out. Oh my gosh, what if coach hates me? Coach is going to hate me if I don't run well. Well, where's my data? What is my relationship with coach? And if I've already done that ahead of time and I know, hey, coach will be disappointed, I'm going to be disappointed too. That doesn't mean he's going to hate me. He's not going to kick me off the team, but we're just going to be disappointed, and that's okay. But I'm going to get that thought in the situation. I expect my heart to be racing all day. I expect to be distracted in class today because I'm really not going to be able to focus because I'm really thinking about the meet this afternoon. But I want to, that 3-component system, sometimes we'll shorthand it, think, feel, do. What am I thinking? What is my body feeling emotionally and physiologically? What am I doing? I'm going to have all of those things throughout the day, and that shouldn't be surprising. When I'm in the situation, I have to learn to endure. And enduring and coping is very different than I did it perfectly. So I might be bouncing my leg, right? I might be like chattering my teeth. I might not focus perfectly well. I might have times where like my stomach is just clenching, and I expected this, and I'm okay, and I can stay in the situation. It doesn't mean I'm dying. It doesn't mean something horrible is happening. It just means I'm really super uncomfortable. One of the most common phobias we see is emetophobia, fear of vomiting. And I think followed by, honestly, is like driving and flying, sometimes heights. But by and far, fear of vomiting is what we see the most often. And it's because you don't always have to be around a dog, but you carry your stomach with you, right? So it gets, oh my gosh, like, but it's constantly cramping up. What if I vomit? And we'll look at the data and ask, like, hey, yeah, your stomach's hurt. How many times has your stomach hurt over the last 3 years? Almost every day. How many times did you think you could throw up? Almost every day. How many times did you throw up over the last 3 years? I haven't. Huh. So maybe those sensations are unrelated to actually vomiting, your fear. So maybe this is okay, even though it doesn't feel comfortable, even though you don't like it. So what we're trying to do is having them start to normalize the distress. So part of this, and we want them to say, hey, it's okay, I'm stressed, and that's fine. That's normal. And in some situations, we do think of it as normal, like right before a game or during a game or in the middle of a test. But when it's overwhelming, that's when we have a problem. So part of it is we prep them ahead of time. Hey, what is going on? Okay. So in the moment, if they're in fight or flight, there's no hold unless they even have a lot of training. So we actually train them by basically inducing fight or flight symptomology to normalize it. That's what we do in treatment. So we have them hyperventilate at home. We spin them around. We have them breathe through really like the coffee stirrers. We do all sorts of things to induce those same physiological sensations to normalize it so they're no longer fearful of them. Okay. In the moment, it's kind of almost too late. You can do grounding techniques. One of them is 5, 4, 3, 2, 1. Look around, note 5 things that you can see, 4 things that you can hear. What am I missing? 3 things, so it goes through all your senses. I'm escaping in a minute, but you just go through it. You can do those. But the idea is to kind of get them kind of recentered just enough. But remember, they're still freaking out because we haven't dealt with their underlying cognition. So you're never going to get them down to baseline in that moment because they're still experiencing that. The bear is still in the room. Okay. What do we do afterwards? How did it go? And we're actually going to review what my fears were. Did they actually happen? Oh my gosh, I did turn red when I was giving a speech. Yeah. But did you finish the speech? Yes. Did you get a decent grade? Yeah, I got a B+. Great. Did anyone laugh at you? Did anyone make fun of you? Did all your feared outcomes actually happen as opposed to I was worried about? As you looked around the room, what did you see? People were bored. Yeah, that must mean my speech was horrible. No, it means that if look around when other people give their speeches, and what are you doing when they're giving speeches? You're bored too. Why? Because you don't care about their speeches, right? So that's that same thing. So just starting to recognize, looking those underlying cognitions and helping them before and after. In the minute, it's kind of late to do that. Okay, so I already talked about the 3-component system. You guys can have these slides. I forwarded them to Joy, so she has them if you want, or you can just email me. I can just send them to you as well, so you can look this over. But that's what we're talking about. That think, feel, do. Again, what's the underlying cognition? That makes a huge difference because social is going to be different than panic versus generalized anxiety, right? So that really helps us set the stage of how do we help that individual if we know what their underlying thinking is. Am I afraid of the physical sensations versus how people will view me versus will I really get into college? Right. Or if I don't do well in this test and I'm not do well in this class, if I don't do well in this class, my GPA is going to go down and then I may not go to the college of my choice and then my parents are going to be mad at me. Right. What's actually kind of going on? Okay. When we talk about clinical approaches, so that's classroom stuff. Clinical stuff is I'm a big proponent of CBT because honestly, that's all I know. But we do know for anxiety related sort of like OCD, this is the modality. In other areas like family, in other words, in other areas, it does no worse than any other area. So it excels in certain areas and does no worse than others in other areas. But again, we're challenging those cognitions. So we talk about thinking about our thinking, metacognitions. Does my thinking make sense? Not just this is the way I think. No, I just know I'm going to fail. Well, why? Where's your data? I'll hear this all the time from my like the 4.0 students. I just know I'm going to fail this test. Well, when's the last time you actually failed the test? Third grade, right? So then you actually ask them, where's your data, as opposed to how do you feel? And then we start to having them identify their irrational cognitions, like emotional reasoning. Just because the more I feel it, the more it's true, as opposed to where's my data? Just because I feel like the plane's going to crash doesn't mean the plane's going to crash. Where's my data? What makes sense? Why is everyone else still getting on the plane? How come everyone else isn't like weeping and crying as they get on and filling out wills, right? Why? Because they know it's relatively safe. Because that's what the data says. I don't feel safe. I feel uncomfortable. That's very different than I am in danger. So one of the big things we'll say is scary and dangerous are not the same thing. Scary is fine. Dangerous is not. Okay. Dialectical behavioral therapy is great for emotional dysregulation and recognizing a lot of those underlying emotional issues, as is ACT, acceptance and commitment therapy. The big difference between CBT and DBT and ACT is the CBT has a focus on actually going out and practicing things that scare people. Right, we want to normalize it to the point it's no longer scary. So we have people like for obsessive compulsive disorder, like the classic kind of contamination. By the time we're done, we're literally with our patients jumping in dumpsters. Why? We want to normalize that and recognizing it's uncomfortable and it's fine. We vomit with our patients. Why? It's uncomfortable. We don't like it and it's fine. Rather than it's so disgusting or so gross or so scary, we shouldn't do it. Hey, no, we should do it. Let's still get so used to this. It's not a problem. And our thinking pattern changes. Our underlying cognition changes. Hey, that doorknob, yeah, I don't like it. It looks kind of gross. There seems to be something on it, but I was in a dumpster, so why do I care? Right. So it's changing the way that we think. And that's what we do in a lot of CBT. A medication can be useful. Remember, medication, and this is the misnomer or the misunderstanding is people think it gets rid of things. It just decreases. The way that people describe it best to me is like with generalized anxiety disorder, it decreases the intensity or the volume of that intrusive, scary thinking. It doesn't get rid of it. It just makes it more tolerable. It turns down the volume knob. But as soon as we come off medication, what happens? Volume goes back up. Okay, so it doesn't actually address the issues, but can help, especially in short-term issues. Okay, we know talk therapy, essential oils, so some things just don't work. Okay, common issues, real issues versus the abuse of the system. When do people take advantage of the system? And we know this happens all the time. All right, I will have people call me, can you write a letter for my daughter? And the answer is no. But the question is there an actual issue? And then we need proof and evidence. And one of the big things that often comes up is why can they perform in one situation and not another? And that goes back to the way of thinking. So sometimes, especially teachers get mad, like, how come they can't stay in the room for a testing situation, but they can go to the football game, right? And they say it's too crowded, but it's crowded at the football game. Well, it's outdoors and they can leave. They may not be able to do that inside in the classroom. Why? Because I have panic and, oh my gosh, I'm not allowed to leave. Where at a football game, it's outside. And if I need to, I can just get up and leave. So it's a different demand characteristic of that situation. So we talk about accommodations. Again, you have to figure out what's actually going to help the person perform better. That's the goal. And ideally, at what point do we kind of integrate them into a regular classroom setting or situation? Okay. I know I'm moving a little bit faster because I'm watching time too. When we refer out, one of the big things about referring out is you want to stay in good contact so you understand what they're doing and what's going to help or hinder their treatment. And there should be a good flow of information. If there's not, then we're already having a problem because I don't know what's going on at school. They don't know what I'm doing in treatment. And sometimes we're going to, by nature, butt heads. So we got to have this good communication across these things. Okay. Concepts. This is just kind of an overview again of what we talked about. Acute versus chronic, clinical versus counseling. Is it school specific or global? And what is the purview of school? What should the school actually be addressing? The way I was taught was, as a school psychologist, it ends at 3:00. It ends when the academics are done, it's a nice clean line to draw, but it's not always that clean, right? Because we have after school sports, we have other activities that may affect it. We have activities that go on in people's houses that they bring back to school the next day that are a problem. So there's still, it's not that clean, but that's generally like, hey, what are we doing to make sure that the school environment is solid for the kids so that they can learn? And again, how do we do it in a way with a minimal impact on the school system? You guys are already overtaxed. You got enough things going on. So how do we make sure that we minimize that or a way that we can do it with the most efficacy with the least amount of effort in that, right? We're trying to avoid the 20/80 rule. Okay. Very briefly, here's some resources. That's actually, yep, that's my phone number. My wife says I have no boundaries. So feel free to give me a call, including after hours over the weekends. I will pick up when I can. And if I can be a service to your guys' schools, I'm happy to do either parent talks, which we do all the time, if workshops for faculty, staff. If I can be a service to you guys, feel free to give me a call, be it a consult on a case to, hey, we could use some more information on something. However, we can be a service here at OCAC for you, we are happy to do. Our goal is to make sure that we have good information going out to providers and to family members and to people who need the help, that there is help for anxiety disorders. It's short-term anxiety disorder. Our average is about, I think it's 18 sessions across the board. It's skewed by OCD. OCD is about 30 sessions. Panic disorder is 12 sessions. We can do it as short as a week. The goal is to get people in, train them, and get them out. And that's kind of what we do. That I could share more. I want to make sure we have at least 15 minutes for questions. I know I ran a little bit long. I apologize. So let's just open that up to questions that you guys might have. And I'm going to pull off this PowerPoint so I can see everybody. Sorry.
Just to make sure that I understood the last bit correctly, you said that there was like opportunities for like professional development, or like if we wanted to get like a extra credential or something added on, so that we can.
Sorry, not credential. We're not doing a credentialing program, but I'm happy to come and talk to your staff or faculty about how do we deal with anxiety or OCD, hair pulling, things that are kind of out of the norm for a lot of people. That's all we do. So if there's things that we can help with that, I'm happy to come. We've done it where if there's we've done CEs, but it's usually someone else's program. Right. So very often we've done it for teachers where they need to do 5 hours or something, and we'll step in and do like 2 or 3 of those hours for OCD or something similar to that. We're happy to do those sort of things if it's already set up, but we don't have our own credentialing program.
Thank you.
Other questions, things you guys are kind of wondering about in terms of anxiety or other issues?
I have a question, Dr. Hsia.
Yeah.
It feels like there is an increase in sort of achievement culture, like excessive achievement culture over the past couple of decades. How do you see that as correlating to like clinical anxiety disorders, and also, you know, the more minor things? And obviously, is this rise, I think anxiety is something that the schools are seeing a lot more of than they have in the past. Is it because we have a greater understanding, or is there like a true rise? What are your thoughts on that?
That's a good question. And the way that I would generally think about a lot of these questions is what variability is due to what? Right. So in the same way that, hey, we've seen a rise in learning disability, we see a rise in autism. Has there actually a change in the amount? Probably not to a large extent, but we're much better at identifying it, number one. And number two, especially for autism, if autism rates look like they're increased significantly, but one of the reasons is we know we can get services if we code this kid with autism, right? There's more money for it. So sometimes people are being misdiagnosed on purpose because we know we can get services for that kid because now they're diagnosed as autistic. And so there's different reasons for that. I would say there is a significant increase in the amount of demand on our students, right? A lot of high schoolers, I mean, the amount of things they have to do to look decent for college is just incredible. It's overwhelming. And I think at some point that there's going to have to be a shift because it's just too much, but they're under this enormous stress. So be it their peers as they're applying to, you know, really good schools and they feel like they have to do the same, to what the schools are requiring, to you look at the admittance rates, to, I mean, there's just so many pieces that are kind of broken. It's hard to tell, but the end result is kids are under seemingly a significant amount of stress. And I think also with the way that social media is, we're much, much more aware of it as well.
Thank you. Anyone else?
It might be a difficult question to answer, so I'm hoping you're probably the best person to ask. In terms of just talking to high schoolers from freshman to senior year and talking to them, provide them psychoeducation about anxiety, stress, what are some items that you would suggest we focus on? So hopefully they take something away from that discussion.
That's a great question. One of the things would be, what is normalized stress? And they kind of see that, right? Normalized stress, part of that's actually good. You want some level of stress. When it's interfering and distressing, when it's causing a problem, when they can't perform because of it, that's when we need to get help. So it's one of the big distinctions, right? Is, hey, we want to stress the system. But when it's breaking or things, I'm not performing as well because of this high level of anxiety, now we need to get help. And with the help, we know what works. So we know talk therapy doesn't work. We know talking about the past doesn't work. We know what does. So the way I'll generally say it is, hey, if you're just sitting around talking for 45 minutes, it's probably not going to be efficacious, right? If I'm trying to learn Spanish from you and I show up once a week for 45 minutes and you talk to me for about 45 minutes, we practice a little bit, and I do no practice during the week, and I don't do anything until I see you for next week for 45 minutes, how long does it take me to learn Spanish? I'm not going to learn it. So it has to be an active form of treatment. The parallel would be like tutoring or coaching or something similar, where there's actual change in that system, which means there has to be work outside of that 45-minute period, which means there should be homework, there should be readings, there should be workbooks. So we're changing how we think and how we behave on a regular daily basis. In the same way that if I go to you as a personal trainer, I don't do anything other than the 45 minutes once a week with you, am I really going to lose those 10 pounds or gain 5 pounds of muscle? Not going to happen. So we're looking for actual change, which means treatment should be based on an active approach. And there's identifiable goals that we've set. But to normalize distress, normalize it and move into it. And as much as I can handle it, I should learn to handle that, right? That's part of what high school is. But I also need to recognize when I'm overwhelmed. And when I'm overwhelmed, I need help. And there is specific types of help that can actually be of use. Not just who's near me and who will my insurance cover. Do you do cognitive behavioral therapy? Do you do dialectical behavioral therapy? How many sessions should this be? What play work or what role do I have as a parent? What should be done during the week in between before we see you next? Not just, oh yeah, we're still figuring it out. We'll talk next week, right? That might happen once or twice, but on a regular basis, we should be active. Great question. Other questions? All right, I guess everyone's doing an outstanding job at school, which is a great thing.
I was going to ask one more thing about social anxiety post-COVID. Can you talk a little bit about, how kids are doing and what
Yeah, that gets interesting because it's also pushed the culture of online. So I have patients who have they have online dating only. Like I have a girlfriend and she's like 200 miles away and we're just online. So we have these interesting shifts culturally. We have it exacerbates situations. So very often, remember, we have an exacerbation of a pre-existing situation. So if I'm already socially uncomfortable and now through COVID, I don't have to go on, and in fact, I don't even have to put my picture up, let alone a video, like a live video feed of me. Stepping back in the classroom can be very daunting, right? So that's kind of a exacerbation of a pre-existing scenario, as opposed to, I remember going, just coming back out of COVID and like shaking people's hands and like trying to interacting, like, oh, this is kind of weird, right? So some of that is normal. So trying to figure out what is a normal response versus an abnormal response. And the way I'll kind of describe it is, hey, look, if we're taking a test, everyone is here. I want you here and anxious with everyone else. I don't want you here. This is unreasonable. This is going to get in your way, but I expect you to be where everybody else is. I don't expect you to be cool, calm, and collected 100% of the time. I just want you where everybody else is when they're stressed too. So you move more or less with everybody else. You might be a bump higher. That's okay. But I don't want you so much of this interfering. So same thing with social anxiety is, again, thinking about how do I do these interactions, as well as what is my internal dialogue, or again, we talk about that metacognition. What am I thinking? Oh my gosh, they're not listening to me. What am I saying? I can't believe this is so horrible. I should just go home. I shouldn't do this anymore. I can't do it. Right. So a lot of that thinking pattern is what we really want to address. Can I do it? How I did it 5 years ago. So there's no reason why I can't do it now. It's just uncomfortable. I don't like it. It's not my preference, but I can do it. And it's to benefit to me. It's benefit to me if I do it. And that's the other thing we kind of look at is kind of weighing the consequences. If I engage in this behavior, I'm going to be anxious and uncomfortable, and I'll be more successful in the long run, as opposed to the short term. Oh man, I got out of the situation. I skipped class. I feel so much better. But now my teacher's looking for me. I'm behind academically, and the other kids are wondering, hey, where were you? And oh my gosh, I can't face that. Now, what am I going to say when they ask me, where were you? Right. So it's just going to continue to build. So it's looking at those, what are the consequences of my behavior, and what's going to be a wise choice rather than making an emotional choice. I feel better because I skipped class. Oh man, I feel so much better. But it doesn't help me in the long run. So even though the anticipatory anxiety, which is almost always worse than the actual event, is very high, it might be worth it to do it, even though I'm uncomfortable, because I know the long-term benefit's going to be there. I have one of those right now who's panic disorder, and he stopped going to Brazilian Jiu-Jitsu, and he loved going. And it's been months, and we just got him to go back to his first class. And a lot of it is like this high level of anxiety, but we walked through all of it. Why would I want to? I said, hey, you don't have to, but do you really want to do BJJ anymore? And he's, yeah, I really love it. I like the people. There's just, I just feel overwhelmed. And we've gotten to the point where he's done everything except for that. And he's just, okay, so then either don't go and be okay with not going, or recognize the consequences. You're going to be freaked out. You're going to have panicky. You have these racing thoughts. You're going to be uncomfortable with the first 10 minutes of class, and then it's going to calm down and you'll be fine. Is it worth it or not? And having those discussions and helping them recognize what's the cost and what's the benefit and the cost of doing these behaviors, rather than I just feel. So we want to acknowledge the feelings, but we don't want when our data and emotions split, we want to follow our data. And we don't want our emotions to make my decision. They can inform my decisions, but they shouldn't make my decisions.
Thank you for that. Can we have a few school nurses participating? And I wonder if you could just really quickly touch on the somatic issues, the kids who are coming in with stomach aches or headaches and things like that. Probably the nurses know pretty quickly who's who, how that all shakes out, but can you just touch on that a little bit as well in our final few minutes here?
I'm sorry, are you asking me or the nurses?
You.
Okay. So sorry. So one of the things we'll see a lot is like stomach aches, right? My stomach hurts. My stomach hurts. That's an easy one to kind of, we'll see a lot of, right? Sometimes it's like, I just like my body's kind of like tingly. So when we have all these sensations, I can't feel like I can focus. I got a really bad headache. So when we have these kind of general complaints, so it's very rare if someone will say like, hey, like my elbow really hurts, and that's what's really driving it, right? It's usually kind of a broad base, but it also doesn't make a lot of sense. My stomach hurts. Why? Because if I'm having a fight or flight response, my blood's leaving my core to go to my major muscle groups, my quads, my pecs, my lats, my glutes, to run and fight. So it does feel that way. So we would never say, no, you don't feel that. You might say, absolutely, you feel that. And in fact, they're probably hypersensitive and hypervigilant to those sensations because they're very aware of it, because they're scanning and looking for those sensations. But that's not the question. The question is, can I still perform despite feeling this way, rather than because I feel this way, I have to stop. And that's one of the things we have to start to normalize. Is it so bad that we need to address it? Rather than because I feel this way, I need to stop. Right. So if we look at sporting, right, we get this idea of like, hey, yeah, like my arm hurts, but does it hurt so much that I don't want to play if I love that sport? Right? A lot of people are like, I'll play through the pain. Why? I love this. This is so much fun. We want to have that same approach when we're in the classroom. I may not love this, but can I stay in here even though my stomach hurts? Why? Because I need to get this academic stuff down.
Last call for any final questions. Otherwise, I think we'll wrap up here. Thank you so much, Dr. Hsia. This was really helpful. I hope enlightening and empowering for everybody. Any last questions?
It's my honor to be here. I appreciate you guys doing what you do. If I can be a benefit, just call me, email me, text me. We'd be happy to see how we can help you guys out.
Thank you. So to all of the participants, I will also forward Dr. Hsia's contact information and his presentation. This was recorded, so if anybody on your team wasn't able to participate, I can also get that out. And watch for our next virtual gathering will be on January 16th. So until then, happy Thanksgiving and happy holidays to all. And thank you again, Dr. Hsia, so much.
My pleasure. You guys have a good day.
Bye.